few minutes ago. So it shows you the 4 seconds I'm examining routinely in the baby's brain. And this here shows the midline falx, the lateral ventricle. Actually, let me show you, let me stand. Okay, so the first thing is the starting examination is that I go to start off and select my probe. So I go to So I select my probes in the top left-hand corner, and I'm going to start with the C229 probe, it's my preferred probe. So when I do that, the next step is to open up the sector width. So I open up the sector width, and now I've got a full screen display. And then I do a sweep running from the cervix to fundus, and then I go from left to right. And as I do so, and then I see where the heart motion is present. So I have a single live baby on board. Then I'm moving to looking at the crown rump length on this baby. And as I do so, I'm looking to see the profile of the baby's face. And as I do so, I'm going to magnify the image of the profile of the baby's face. As I do so, I'm looking and I see here that this here is the brain stem. And as I look on the measurement of the brain stem, and I do distance, generic distance, 2 points. This is the baby's brain stem, and I see that the distance of the brain stem to the occipital bone is increased. This is called the BSOB distance. So that's the first thing that strikes me when I'm looking at the section, the BSOB is increased. I save that image to the file. As I'm looking at the baby's profile, this is clear, I'm looking at the nasal bone, and I see that this here is the vomer. So I can see the primary and secondary heart mallet that's intact. I have the vomer bone, and then I'm looking to see if there's a nasal bone. So as I look to rewind that, I can see a tiny, tiny nasal bone. It looks small. So as I look onto that, I can see that it's either an absent or hypoplastic nasal bone. In this position, if the baby's lying in a nice position for taking, in the interest of time, I won't measure nuchal translucency, but to me it looks like a very borderline measurement of the nuchal. Actually, let me measure, I changed my mind. Calculate nuchal translucency. So I'm going to take a measurement of the nuchal translucency, and I've got a measurement for 3 millimeters. So it's a very borderline measurement of the nuchal translucency. When you have a nuchal translucency that's borderline increased, there's a very important rule. If the baby's in a good position for examining the heart, then don't waste any time. Go ahead and examine it. It's very important. Because if you wait till later, the baby may shift into a different position, and it may be very difficult to examine. So what I'm going to do next is to go down and examine the baby's heart, and then I will come back to it in the 4 seconds of the break. But as I come down to examine the baby's heart, I'm going to select a preset, a cardiac preset. I'm going to slightly increase my dynamic range. And as I do so, I see that there's a discordance between the left and the right ventricle. So I'm going to record that as cine loop. Next is I'm going to toggle zoom. And as I do a switch, I'm doing a 4-chamber view of heart. And I see the right atrioventricular valve, but the left ventricle is smaller when compared to the right. And then I do a sweep up to the 3 vessels field view, and I only see 1 vessel coming out. And I need to look at the curvature of that vessel coming out of the ventricle. Once I've got that, I save that cine loop to screen. I then go back to the full screen display, and now I look at the power Doppler, and I want to see whether I've got a single or 2 ventricles. When I'm looking at this, I see that there's only a single ventricle filled, and this ventricle is the right cardiac ventricle. And when I sweep up the right cardiac ventricle, I see there's a single artery. So it's important for me to split my screen in 2. To magnify the image, see a single ventricular fill with no fill of the left ventricle, and then to sweep up here and I can see a single vessel coming out of the right ventricle. So now I ask myself the question, why is there no fill in the left ventricle, and why am I not seeing a transverse aorta? So is this hypoplastic left heart syndrome, or is this mitral atresia with VSD? So I saved this cine loop clip to the drive. Again, it's important for archiving if you save cines. It's not set up for cines. You set up quickly. So we set up the machine for cine loop recording. have this for any baby when you go back later and have a look. It's important to have set up that you automatically save synonyms, so when you go back later, if you've missed a cardiac abnormality, then you can have a synonym which you can go back and track and record and say, yes, I've learned that I'm back and looking at the examination. No, I don't P1, sorry, just change P1. Oh, P2, fine, thank you. Okay, so now I've saved the synonym. You look at the bottom left-hand corner, I now have a synonym. If you're running a department, it's very important that you have that set up in the machine. So if we come back to this same patient, I'm now going to use the slow flow to get details of any fill inside that left ventricle. When I've got slow flow, I'm going to go into 2D and split my image, and then within the setting, I'm then going to turn my background off.
Đây là công nghệ slow flow và chọn cái background off để có thể thấy cái dòng chảy nó tốt hơn và cấp lượng vi mạch rất là tốt trong cái khảo sát tim thai quý 1.
Long, is there simultaneous translation or not? Do you know? Or do you want to translate for me? Is there simultaneous translation? That's so good. Okay, thanks, Long. Thank you. Feel free to do that again, Long, if you want. So when we are looking at this 4-chamber PFR, I am still only getting fill of the right cardiac ventricle. And now I want to know is there any fill of the left cardiac ventricle through a VSD? I'm not seeing that. So I'm going to go back to 2D and then rotate my transducer looking for a left ventricular outflow tract to see if I can get any signs if there's any evidence of mitral atresia. Because it is likely when I'm looking at this that I'm looking at aortic and mitral atresia. I also need to check when I'm looking at the heart, because the other possibility is I'm looking at a univentricular heart with a single AV valve going across. That's another possible diagnosis. But I feel that the apex of the left ventricle goes further, and therefore I think it's biventricular, not univentricular. So if it is biventricular, you need to check, because this could be an AV canal defect. It could be a biventricular heart with an AV canal. It's very important that you turn down your synonym and you go very slowly, looking to see if there are two separate valves. And if I look at that valve, I think that's the right AV valve. And I've got a slightly oblique section through the heart. You may find it helpful if you then change your transducer and then move to a linear 9 transducer, you may get better detail on the 4-chamber. So if I go select linear 9 for semester cardiac, and then I go to the 4-chamber of the baby's heart.
Hãy sử dụng đầu dò AQNL, đầu dò lay như tần số cao để khảo sát cái trường hợp này, để xem tần số cao và cho được phân giải tốt hơn.
So as I'm looking at this on the 4-chamber view, I'm looking to see whether the linear 9 provides a little bit more detail, but the baby has just moved already. So I might just come back to the heart in a second. So I'm now going to continue examining the rest of the baby because the heart is moved into a back position, which makes the point at the very beginning I said to you why it's so important that you're in a good position to go ahead and examine it. So next I'm going to go and examine the baby's brain. So we'll look at the brain. I want to look at the sections of the brain. So as I come across into a 4-chamber view, I can see that the nuchal fluid looks prominent. So the very first section of the brain is just showing the choroids. So I go into a full-quadrant analysis, I magnify the image, I can see the choroids on both sides. It seems to be the choroids are relatively small compared to the size of the lateral ventricles. I then come to the next fluid-filled space, which is the cavum venom depositum. I then see the aqueduct of Sylvius, and I measure the distance between the aqueduct of Sylvius to the occipital bone, and this should be more than 2.5 millimeters. In this stage it's going to be around about 6. So 5.9 millimeters. And then I next move to looking at the cerebral port ventricle. And as I come to the cerebral port ventricle, I can see the cerebral port ventricle is dilated. So this bar of tissue here, if I do a generic area trace. This band of hyperechoic tissue here is the choroid, which lines the roof of the fourth ventricle. It's referred to as the choroid bar. And I want to look at the choroid bar in more detail to see if there's interruption of the choroid bar. So that's the choroid bar, and this is the dilated cerebral port ventricle. A dilated cerebral port ventricle is a marker of trisomy 13, trisomy 18, and digonic trichoid. But this baby has had a chorion biopsy confirming that it does not have any of these conditions. It is also a marker for also a marker for microdeletions and duplication. And again, this baby has had a chromosomal migrate alluded to this. So when I see a dilated cerebral fourth ventricle with normal chromosomal migrate, and then you see the signs of a Blake's type cyst or Danny Walker malformation. So I clear my image, I press P1 to record prospectively to the USB because I save my cases, and then I come down and I see the aqueduct facilities, which looks very normal. And then I come down to see the fourth ventricle is dilated. So now, once I see the fourth ventricle is dilated and the aqueduct facilities is normal, this is likely to be a Blake's type cyst, not Danby Walker malformation. And Blake's type cyst has a very good prognosis. So I'm going to outline for you the fourth ventricle, or the whole space of the fourth ventricle, which is dilated. And the structure that's anterior to the fourth ventricle here is the brainstem. So this is the brainstem. If you want to, you can measure the distance of the brainstem, which is from this point here to this point here. That's the brainstem thickness. And I mentioned before that this all white area outside here is the choroid. But the important thing is that the aqueduct facilities, if this was obliterated and the fourth ventricle is dilated, it's more likely to be a Danby Walker malformation. So I save that scene to dry. Once I've got the baby in this position, I split the image and I demonstrate, when I look at this, the alveolar ridge, and then I come down to the mandible. So this here is the mandibular gap, this black hypochoric area. And this here is the maxilla. Here is the maxilla. And this here is the lip. So I can tell you straight away, by looking at this baby, I can tell you that there is no cleft lip and there's no cleft palate. Because this here, if I trace it out, is all the upper lip. And the upper lip is intact in this baby all the way around. And I know it's the upper lip because I can see the shape of the maxilla. The maxilla is a wide angle bone. I do generic, I just measure heart distance, generic distance. If you look at here, it's a very wide angle bone. Whereas the mandible is a very tight angle bone. Look at the angle of the mandible. And there it's almost like at 90 degrees. And that's how you know whether you're scanning the mandible or whether you're scanning the maxilla. So in a single sweep on that image of a split image, I come down and I see that the maxilla is fine and the mandible has got the gap. The gap tells me that there is no retromedia and no micromedia. This tells me there's no cleft lip. As I come down to this, I also see the orbits of the eye. So as I look onto this, I can see this is the lens within the eyeball, this is the orbit, and if I use ciliary review, I then see the opposite side that I have the other lens within the eye. Slow flow is beautiful technology because it allows you also to see absolutely tiny vessels. If you look at this baby, you will be able to see the vessels that come down and supply the orbit of the eye. As you come down, you can see this in either transvaginal or abdominal examination. You can track the tiny little vessels that supply the eyeball. So this is the retinal artery coming in here to supply the eye. And you can also track the other three branches that go around, the nasal ciliary branch here, and then the other branches that go around the eye. I'm showing you this just to show you the power of this technology. And then this shows you the circle of Willis. You can follow the branches of the circle of Willis. You can see the posterior communicating artery here, and you can follow the anterior communicating artery here. The anterior communicating artery is an artery that is missing in babies with holoprosencephaly. And this is a very useful marker in determining very early in the first semester of pregnancy. But this shows you the power of slow flow of an abdominal scan. And then you can see also here your superior sagittal sinus tracking down. So as we move back down to the baby's hands, we see the image. You see the arm, 3 segments of the hand. Turn up your dynamic range. You see the humerus, you see the radius, the thumb, and the 5 fingers. Then you update over to go to the opposite side. As you look at the opposite side, you see the finger, thumb, 5 fingers, and if you want to then jump in the same image, make sure that you're examining a separate arm. And you see there, you can see the humerus, radius on that, and then come on straight. You see that there's a thumb, and then come across that there are 4 fingers in this baby's hand. So it's important in a sense when doing a scan that you don't end up examining the same hand twice. And by splitting the image, it stops you doing that. When you take a sample section of the baby, you can see the diaphragm here, the lungs fields which is brighter, turn down your gain, and you can see the anterior abdominal wall. Once you've got the anterior abdominal wall in view, you can then move to moving slow flow and split your image in two, and then you can demonstrate your intrahepatic vein. As you follow down to the ductus venosus, you turn down the gain because it's very, very sensitive. And when you turn down the gain, it may help get rid of background interference. And now you can see the point of the cord inserts into the abdominal wall. You can track it down to where the point enters into the ductus venosus. It's important to make this because you want to make a diagnosis of absent ductus venosus, not in the second trimester. It's a diagnosis that you want to make in your first trimester. You can also pick up interrupted IVC at this very early stage in the pregnancy. If the baby is extremely active, then come back and do slow flow later on. As we come down to looking at the baby's legs, the spine, we look through the kidneys. The kidneys have got renal pelvis dilatation on both sides of this baby. The kidneys are quite hyperechoic in the first trimester of pregnancy. But as you look at this, you can turn around and then look to see both the renal arteries. So you put on for this on the slow flow, and once I've got slow flow on the arteries, I look to see whether there's a single renal artery or there are double renal arteries supplying the baby's kidneys. You can look at both 2D and in colour, and when you look at this, you'll see not only are you seeing the renal arteries, but you're also seeing the vertebral arteries supplying each individual vertebrae. You can see the artery supplying the kidney, but you can also see the suprarenal artery, which is supplying the adrenal gland just coming in here. So it just shows you the power of this technology of looking at really tiny vessels coming in to supply the baby's kidneys. So when I look at the kidneys on coronal section, I can see that there is renal pelvis dilatation. I'm going to take my background, put my background on off. You can see if you wanted to look specifically at the bifurcation at the aorta into the common iliac. You have your division of the anterior, the internal and external iliac, and then continuing down to the fetal femurs. And you just crank up the gain, you will then find the profunda femoris coming down. Again, just to show you the power of this technology to get the femur in view, you'll be able to see the tiny vessel coming down into the leg. And I come out coming out of slow that I look down to look at the baby's legs. So I just go to the back into this view here, then down to the base of the spine, and then onto the fetal feet. When I look at the fetal feet, I'm looking for the three segments of the fetal feet. I'm looking to check the angle of the foot comes off the lower leg, which looks normal, making sure that there's no talipes. So the angle of this foot comes off the lower leg spine, and the fibula and tibia are present. I confirm that both feet are present. I can come around and look at the digits of the feet, and look at the individual bones of the feet. You can use Cineloop to rewind, and you can take the shoe size. So the shoe size at this stage is the order of, not that this is important, but mothers like to see this, and you can measure the size of the shoes. So the shoe size in the order of 12 millimeters. But importantly, you can see the individual bones. So we've seen both legs, both lower legs, both feet. The cord insertion to the abdominal wall, very important to see that, so we just do a HD zoom, and we see the exact point where the cord insertion to the abdominal wall. When we do that, we can do a split image and demonstrate both umbilical arteries running either side of the urinary bladder. So we come down and demonstrate both arteries coming in. There's the right and left umbilical artery. You can get a little bit more detail on that. So you fill that up. You see, I now want to look at the urinary bladder. So the urinary bladder, there's no urine in it, so I would wait until this fills. It's beginning to fill now. But I would not go home until I see the urinary bladder in this baby. I see the renal pelvis about that age, so I know there's almost certainly urine production, but still, the course of an empty bladder would be bilateral regenesis number 1, and then bladder extrophy number 2, and cloacal extrophy number 3. But I look at the bladder, both on the umbilical arteries there, they look normal. So as we come down to look at the rib cage and the spine, if you look at this, you can see the individual ribs. You can count the ribs if you want. You can see the spinal cord going all the way down. You come across the baby's face, you can look at the retronasal triangle. So you come across the lips, we magnify this image here, we see the nose, the upper lip, and see which is continuous, the lower lip, and then our true lip to the retronasal triangle, back up into the orbit. I'm going to come down to looking at the next thing to become another patient. I'll just come back to have one more look at the baby's heart. So I'm just going to come back and look at the four chambers of the heart, see if the baby's moved into a better position. And also, if I can try. I just want to see the nasal, whether there's a nasal bone. So I just can't see a nasal bone. So, just record that. So that's a nasal bone. Dilation towards ventricle. And then go to the, now just back to the four chambers. So I just want to take some more images of the four chamber view of heart. So I'm going to just HD do that once more. And I just want to go through the cardiac settings. So first of all, you can look at the color. When you look at color, your PRF needs to be somewhere between 25 to 35 centimeters per second. So if you look in the top left-hand corner, that's at 23 centimeters per second. My screen is actually covering it, you can't see it. But up here in the top left-hand corner, the PRF is 23 centimeters. So when you look at color, that's the first Doppler session you can look at. And you do so, you demonstrate the flow into the right cardiac ventricle, and then you demonstrate the cardiac outflow tract. And that's your RVOC. Then you can, after doing that color, you then do the exact same exercise, you switch to power. And at power, you're up to 25 centimeters per second, the exact same. Increase the acoustic output, try and maintain the mechanical and thermal indices, less than 1 if you can. If I pull it back a little bit, my power, I'm just bring it back to 1.1. So this is where I want you to look up here. It's down to 0.7. So I can afford to increase it just a little bit more. I'm now 0.8, 1. Okay, I'm happy with 1. And then I do the exact same exercise where I split the image from the four chamber view of heart, and then increase the color gain, and then split my image showing the ventricular outflow tract and power. And then the last control is to show is with slow flow. So there are the three ways of looking at the heart using those three technologies: color, power, and slow flow. When I'm looking at this at the beginning, I'm going to turn my background off. Background on. And again, I'm just looking at slow flow to see if there's any fill of that left cardiac ventricle. And then as I sweep, I do the exact same exercise where I put the four chamber on the right hand side of the screen, where I just show the right ventricular fill. I put that in red, and then I update my image to show the main pulmonary artery coming out of the right ventricle. And then if I look at here, I want to check and see, I'm looking at the subclavian artery. And that is the left subclavian artery. But you can see that this subclavian, the tiny little branch subclavian artery is coming off here. When I see that there's only the left ventricle, I want to know whether there's reversible flow along the transverse aortic arch. I then come off slow flow and I go back to power Doppler, take off slow flow, and now I want to look for reversible flow. When I'm looking for reversible flow, I magnify the image, and now I bring down my PRF, increase my output, and now I'm beginning to see reversible flow along the transverse aorta. So this is the main pulmonary artery, this here is the arterial duct, and this here is the transverse aorta. So I can tell you that this baby has got a duct-dependent lesion. The findings are consistent with a hypoplastic left heart, which is related to mitral atresia, aortic atresia, with a reversible flow along the transverse aortic arch. And to bring the aortic arch into view, the only way I could bring the aortic arch into view was by turning down the PRF to 13 centimeters per second. And now you can see that you can demonstrate that flow.
Thầy chuyển sang bệnh nhân thứ hai ạ. Hội trường mình có câu hỏi nào dành cho thầy trong bệnh nhân thứ nhất không ạ?